Yeah.
It is a great pleasure and a privilege to welcome to the 20th Complex Coronary Interventions webcast, Dr. Kambis Mashayekhi. Dr. Mashayekhi is one of the best European operators in CTOs based in Germany, and he's going to share us some complex cases on epicardial collateral, ipsilateral epicardial collateral CTO. This is actually an area that he has created to a large extent, developing a lot of the literature and the techniques involved in that. So we're super excited to hear him present those cases. And before we start, just to thank our sponsors, Terumo and Abbott Vascular, for sponsoring this webcast. So Kambis, welcome again. Thank you so much for being on the webcast, and look forward to learning from you.
So thank you, Manu, very much for the invitation to this excellent platform. And as you can see, Manu, we are talking today about efficiency in complex retrograde CTO and the role about epimyocardial collateral connections in ipsilateral CTO PCI. As you know that in Europe, we are not all used to the dissection reentry systems and to stimulate balloons. So it's getting more and more now. But we have to find sometimes some different pathways to get a retrograde wire in to solve the case. Probably that's also one reason why I have to deal with so many epicardial collaterals. So I will just start. These are my.
Quick question, Kambis, on the previous slide.
Yeah.
So there's different colors for different centers. Do the colors mean anything on the upper left, or is
Okay, that means this is now the community around Europe who is sharing the Euro CTO Club with associated and affiliated members, and that's just from the Euro CTO. These are where the people are working and where they are living, and the different colors mean if they are full members or only associated members, or if they are organizing members from the country organizing members. So that's all about. Yeah.
Perfect. And actually, for the U.S. crowd, the audience, because this is a group we don't know very well, Europe has many centers, has a huge club, the Euro CTO Club, going on for a long time, many high-impact papers and an excellent database putting the cases. So for everyone in the U.S. who wants to learn a lot, the Euro CTO Club has been instrumental in teaching us on CTO PCI. Thank you very much, Manu.
Yeah, we started 2008, as you know, and it's really now, so we're putting about more than 2,500 data in the database, and up to now, I think we have more than 24,000 people in the database. So we're going to start. These are my disclosures. Regarding the retrograde strategy, when I'm doing a lot of proctoring around, and the question is always, when are you going retrograde? At which point should you go retrograde? So in Europe, so as what we are doing is, as everywhere, we are doing a dual injection. We check the antegrade cap. So when we have a tapered stump, what we do is sometimes we have a good chance we get 2-2 with a soft polymeric wire, filled XC, for example. But when we have a blunt stump, we often let up in a subintimal space. So when we are in subintimal space beyond the distal cap, so I'm always thinking about the retrograde landing zone. And what I tell people is if the landing zone is big, more than 3 millimeters, so it's worth to try a second wire. I know that it's not so common anymore in probably also in the US, but we are still doing a lot of parallel wire technique. So if the landing zone is less than 3 millimeters, we check the GCTO score. If it's low, so probably there is still a chance to get antegrade with parallel wire. If it's high, more than 2, then we put a retrograde wire in, and if we have here a failure on retrograde wire, we could come back to dissection entry or IVUS-controlled dissection entry. So that's my personal modus of how I get through CTO procedures. When I have a retrograde wire in, the first thing that I try is to do a direct wiring with the wire. If this fails, I try to do antegrade wiring. So I have a retrograde marker wire, and I try to puncture through this retrograde marker wire with an antegrade wire. If this fails, I come to contemporary reverse card. So what I try is to use a small balloon when the wires are nearly together, 2.0, 2.5, and I don't try to open up the subintimal space very big with a big balloon. So I try to make a small trauma to the vessel, small balloon, and then to puncture in. If this fails, I check IVUS and try to puncture under IVUS control with the retrograde wire in the antegrade to the antegrade IVUS. And if this fails, then I have to go to reverse card, and this is my retrograde strategy.
Perfect. Kambis, can you go back one of the beginning?
For sure.
Like, it's a great one because there's a lot of discussion. If you go back one where you see your algorithm, which I like it very much. It's a very good way to put it together. So, you know, here we start with dual injection, obviously, same starting point. And then sometimes we do retrograde first if the cup is not very clear or, you know, the patient has failed undergrade before. Do you ever do this, or you always try undergrade anyway? That's a question many people ask. Do you always try undergrade?
Yeah, that's a great question. I mean, I have to tell you, if there's ostial occlusion, RCA occlusion, I try to go directly retrograde. The other thing is, you know, the question is, normally you always need an antegrade wire also for your retrograde procedure. So I try to put an antegrade wire first. But if I have a very difficult CTO with a difficult retrograde pathway, a complex epimyocardial pathway, and I have the impression that I end up with two wires, one from antegrade, one from retrograde. So I focus concentrating also on directly retrograde approach, because I use my whole concentration for this difficult passage, as you will see in the next some slides, to this sometimes epimyocardial passage so I concentrate then on retrograde wiring. So, but for any procedure, you need an antegrade and also a retrograde wire. The only thing is sometimes in ostial occlusions. Yeah. Perfect.
That's a great point. And then if you go back, and like your part, as you know, here we do a lot of undergrade dissection re-entry if you go subminimal, but I completely understand that parallel wire works very well. And if you do that, you typically do it with the Crusade or the twin pass, or you just try the two wires alone, or how do you typically do your parallel wiring, since many people in the US don't do this very often?
Okay, so one thing is, it depends on your primary, so on the sheet size, which you are going to do. So if you start with, when you think it's not so complicated CTO, you start sometimes with 6 French, so you can put two fine crosses in, or I start with a normal microcatheter fine cross and a wire, and if this end up in a subintimal space, then there are two options. One is to bring the second microcatheter in, or you just trap it and let the wire there and take a second wire. So when you want to do with seesaw technique, so you want to work on both wires, so you have to use 2 microcatheters. When you only want to have your wire as an orientation point for your second wire, you just let it there, and you can save 1 microcatheter. So that's how we work. I mean, there's one point: you shouldn't do too much damage on the antegrade, on the distal cap on parallel wiring, because when you do a lot of hematoma, creating a lot of hematoma, then also retrograde reverse card technique will be complicated afterwards.
Perfect. Excellent point. And on your next slide regarding the sequence, so I like very much you said direct wiring is great, undergrade wiring is great, makes it simpler, of course. Now, there's a controversy, at least here in the US, about the contemporary reverse card. Many people are saying that they try this and they say they have a very hard time making the connection. And the traditional teaching is, as you know, you just go with a bigger balloon and do a big reverse card. Any of your thoughts regarding how often it works for you, the contemporary reverse card, the small balloon, and the Gaia wires?
So it depends, Manus, I have to say, it depends on how far away the wire is from the antegrade wire. So when they are really nearly together, and when you are doing correctly, so you really check in 2 plans that you have a 90-degree angles through the balloon. This strategy can work in probably 50%. But but if you fail, you have to think about what's the reason of failure, and then I think IVUS is a good option. Yeah.
Sure. Perfect.
Yeah. Okay, so we continue regarding the collateral connections. So we know all the slides from Gerald Werner. Which collateral should we choose? We are concentrating on retrograde approach now, and we have the CC0, CC1, and CC2. I don't think that we have to explain it, but what I want to say is that sometimes in septal surfing, we often use CC0 collaterals, and because we don't see where we are going, and the Japanese don't do this so much often. They are going for CC1 collaterals because they want to visualize it. The main reason is probably on CC0 collaterals is sometimes a little bit more hard on the septum to get the corsair through. So we have now better devices, Turnpike LP, smaller devices that can also follow this kind of collaterals. But when you have a super selective injection, a CC1 collateral, and you can pass with a wire, so sometimes it's a little bit more easier to bring the corsair through than to a CC0 collateral. That's my impression. And regarding big septal collaterals, CC2, they are often also very tortuous. So sometimes, and when you destroy them, they make a big hematoma. So the best thing is probably to go for septal surfing. That's my personal point. And after this, if this fails, I'll do a super selective injection regarding CC1 and try to pass them.
Perfect. And how long do you typically try the surfing for 5-10 minutes or?
You know, the surfing, it depends also on the morphology of the septal collaterals. So when you think that when you have the impression that there are a lot of pathways, it's worth to try this for five, probably also 10 minutes, how you said. But if you can see a very nice CC1 connection, which is not so tortuous, surely you will go for them. Sometimes you have not really very nice CC1 collaterals at all, and it's sometimes also the last option to go for septal surfing. But with the Scion black wire, which I use most time, you have a very high success rate only on surfing. Yeah. Okay. Now we are going to the epicardial collaterals. So this is from your publication regarding tortuosity, perforation risk, and wiring and difficulty of wiring. We know that the epicardials are for sure the most complex retrograde collaterals that we have. And I also like this slide from Dr. Rator, and which shows on retrograde failure and retrograde success rate. So when you want to fail, what he figured out is just take an epicardial collateral, take an CC0, take an very, very tortuous cork type collateral, and then there is a very high percentage that you can't pass this collateral. When you want to have a good success, just take a septal, CC1, not tortuous, and with a great donor and recept angle. But as you will see in the next slides, is that we can also pass sometimes very complex collaterals. So what we did is we analyzed the topography of ipsilateral collaterals of the left and of the right system. That's what I have figured out and what I found out. This is the LAD occlusions, and this is a scheme which we created. So what we can see is that we often have septal interactions, collaterals from the first septal to the mid or distal part of the septum, and which are sometimes a possible pathway for ipsilateral approach. Very often, situation is this type P, from diagonal to the distal mid part of the LAD over epimyocardial collaterals. In left dominant system, we also see from the marginal branch septal perforants who are going to the LAD, and also sometimes from the marginal branch over epicardial to the LAD, or over the apex also to the LAD. So that's a morphological criteria which we figured out. And regarding the circ, what we have seen is that there are sometimes like bridging collaterals from the proximal part over epimyocardials to the marginal branch, sometimes also like cubital arteries, very tortuous, but sometimes they are also good for passing. And the type B is from the first marginal to the distal circ. And again, in left dominant system, from the LAD to the distal circ over septal collateral connections, and from the diagonal to the marginal branches to the distal circ, also epicardial connections, or from the LAD apex to the obtuse marginal branches. So that is the schema which we found out, and We are also going for submitting this topography of ipsilateral collaterals, because I think we are looking really, we will really try to understand the complex collateral anatomy of the heart, and we're also trying to present this paper. Regarding the right topography, we have shown this in your intervention this month. We have also created the topography of the right collateral anatomy. As you can see here, the proximal, the type A is from the proximal part to the distal part to the crux cordis over epimyocardial collateral connections. We have sometimes also very tortuous collateral connections who are going to the PLA branch. Sometimes they are really also going over the aortic root. And type C is from right marginal branch. They are bridging, like often very, very tortuous, not very good passable collaterals. Sometimes it's also interesting morphology. You have the right descendens superior artery, which is giving septal collateral connections to the distal part of the side branches of the RCA. And in this D connections, you will see when you look at this, that the first septal branch of the LAD is not here. So you have almost no first septal branch, because this septal branch comes in this type comes from the RCA here, and can give you collaterals to the distal RCA. And we can also see epimyocardial from the marginal branches to the PLA and PDA system. So,
that the type C is the one you're very concerned about. I think in your paper too, you say that there's ones you're very concerned about doing crossing. It is the type C. Which are the ones that really bother you when you try to write it?
It's really what we can see is type Cs, because they are often very, very tortuous and very tiny collateral connections. I have also passed ones, but I think it's a little bit of limitation. Yeah, I mean, to pass these. I think the safest one is type D if we have it, for sure, and also type B is very good passable. But also I have also a lot of examples where we can show that type E is also good passable. You will see it afterwards in the talk.
Absolutely.
Okay, all right, and these are also the types that we described. So what we did also, we analyzed 440 angiograms, and we have found about in 50% ipsilateral collateral pathways. What you can see here is that in LAD we have also presented them in about 60%, but in the circ we have it nearly to 80%. We always can find some ipsilateral collateral to the circ, and this is also probably the reason that we nearly have very, very less failure rate on circ with our approach. And on RCA, we could find it about, when we checked 261, we find it in 1/3 about approximately. And what's also interesting is that the most of them are for sure epicardial collateral connections. Yeah, and regarding the Retro paper, we checked the passability rates, and we think that it's more than 50% of them should be passable. So I want to show you one recorded live case which I did. It was a live case in my hospital. I would just put this down on because it's in German. And what you can see here is an occluded circ. It's a post cabbage patient because we put a stent in this marginal branch, and it was an underexpanded stent. So some months later he came and had a reocclusion, and then we sent him to surgery, and but the surgeon couldn't get this circ, so he could get the first marginal branch but not the second one, and put a limb on it. So the whole circ wasn't really revascularized. And here you can see a Sion black wire and the epimyocardial collateral. So here I start directly retrograde, and as you can see here, the Sion black just goes in very, very slightly. And I had here a turnpike LP microcatheter, and here you can see also the performance from this great microcatheter vascular solution. And
your preferred
and then we had this huge angle and very calcified cap. And you see this 90-degree angle, it's an 8 French approach. So I tried to really expand the stent with 3.5 balloon and try to puncture with confidence at 12 per minute. But finally, I got a subintimal space, as you can see here. I tried to puncture, and there is the subintimal. I got subintimal, and I couldn't really figure out in IVUS where I lost my subintimal wire, so because it was also very calcified. So what I could do finally is I had this antegrade wire, and I could puncture with a 12-gram confianza through the vessel. So, and on the right side, so I could puncture it. As you can see, it crossed completely, but I did a puncture. And then I could redirect to the native vessel, and I could engage to the antegrade guiding. It was an 8 French, single French guiding procedure, and this is the turnpike. And so I could do externalization with an RG3 wire, and this is after stenting the bifurcation. It's the final result. So I think this is the only way how probably we could treat this vessel is over this epimyocardial collateral, because it was really a bad angle, and I had no chance with antegrade puncture through this because you have this 90-degree angle, and there you can't get a lot of pushability on it. Yeah.
That was a very challenging case, and you said, I mean, it's one of those.
Okay, here is a type B connection. It's a case which was tried in Lithuania, and so, Manus, are you here still?
Yeah, absolutely.
Hello?
Yeah, absolutely.
Can you hear me?
Yeah, I can hear you. I can hear you fine, Kambis.
Can you hear me? Hello?
Yep, hello. I can hear you very well.
Oh, okay, perfect. So pardon me. So this is an ipsilateral case also. It's an type B from the diagonal to the LAD, and we couldn't puncture the antegrade cap. It was an instant occlusion, 15 years old instant occlusion, and they tried it. It was in Lithuania. Tried it multiple times, but it couldn't open the vessel. So can you see here this very tortuous collateral? This was one of my first experience with Sion Black, and I wasn't sure if it's even if we're able to pass this kind of collateral. So what I did is I brought the Sion Black in, and after the third tortuosity there, you can't feel anything on the wire anymore. So you have a lot of resistance. So what you have to do in this case on the right picture is you have to bring your corsair slightly down, and then on CC1 sometimes you will see here that the collateral is stretching up, and then you have a good chance just to go forward. And we had the retrograde wire in, and the rest of the case was not a problem. We checked with IVUS if we don't have didn't pass a subintimal on the left stem, and here you can see on the right picture the IVUS, and okay, this was a photo there, and then we stented it. Here you can see on the left image the spasm of the collateral. I did just to check if there's no rupture, and we didn't destroy anything, and here's the final result. So that was one of a great pathway which we could use to open this vessel. So this is also an interesting ipsilateral case, probably one of the first I did. And the interesting thing is that as you can see here, it was the diagnostic angio that there are many collaterals. One are the conus branches from the right coronary artery, where I have a super selective injection there, and there are also from the diagonal branch epicardial collateral connections. And it was a patient who had a non-STEMI and non-ST elevation myocardial infarction, and the doctor stented to the diagonal. He overstented the LAD, but didn't realize this. And the patient came back 2 years later and said he's not feeling good. So we also checked the right, and we also saw that there are some epicardial and some septal collateral connections. But what we did is we first tried to do a retrograde approach over the right coronary artery. So here you can see also the epimyocardial collateral connections to the distal part of the LAD. So the question is, what should we do first? We don't know how to puncture. One point would be probably IVUS-controlled antegrade puncture through the stent. The other thing is directly retrograde, septal first, ipsilateral, epicardial, first or the conus branch. They are very dangerous, but it's a possible option. But I think you should be very, very experienced on it. So it's the last option, I think. So what I did is I tried to go retrograde over the RCA. And what occurred was a huge spasm after I put in the corsair. And so I couldn't continue with this approach. So what I did is I checked my retrograde pathway. I put a corsair in, and I did a supraselective injection to check the epimyocardial branch. And then I went forward. This was with silent wire at this time. Here you can see. And finally, I was able to pass this collateral. And here you see anchor balloon, because I had not so much. I couldn't bring the corsair over the apex. So what I did is I just I made a knuckle distal, and then I punctured with a 12-gram confiancer to this knuckle, and so finally I get in, and yeah, and this is the result after stenting. So the thing which helped me now very much when I passed this epicardial is the new Turnpike LP microcatheter. It's a low profile microcatheter. It's a 2.2 French distal shaft and 2.9 French proximal shaft. So we have a lot of pushability and a very slippery and excellent microcatheter for epicardial approaches. And what I show you now is, in December we did a first testing with some other centers. It was a worldwide first test of this microcatheter, and I did 3 cases on this day, and I showed you all 3 cases. The first was a 6 French case where I reopened the distal circ. You finally can't really see it very nice, but there is the distal circ was occluded, and the patient had a lot of angina, and so also the proximal part of the circ wasn't so nice. So I did a soft antegrade attempt. I mean, with soft, I did only use soft wires. I didn't want to destroy something. And then I put this Turnpike LP in, and as you can see here on the right picture, it's a cyan black, and the cyan black just could find a pathway to the distal part of this circ occlusion. So as you can see here. And then you can see here the Turnpike LP microcatheter on clockwise rotation, and here I have to start to rotate clockwise, but in 6 French you have not so much support, but this device just went through this nearly invisible collateral, and as you can see here, then it was not so difficult to get in the distal part of the vessel. So what I did is I could go for some externalization there. And then I did a tip-in, a rendezvous technique. So I changed, I dilated the distal part, and I got with an antegrade wire into my distal microcatheter, as you can see here. So I'm 100% sure that I'm still in the vessel structure. I'm still in the right way, and then this after stenting. And as you can see here, how diffused disease the distal circ is. So we didn't treat this, yeah. And yeah, we stented the rest. So this was one of the cases where I was really impressed about this Turnpike LP. As you can see here, this was the pathway there.
So do you ever use regular Turnpike anymore, or you only use LP right now for your retrograde cases?
That's a good question, Manus. It depends a little bit on when I have a very calcified RCA occlusion where I think I need probably a little bit more for support. I still believe that the Turnpike could have a little bit more support. But when I go for epicardials, I only try to use this Turnpike LP. Yeah.
And always see on black as well. It looks like every case.
Yeah.
Black, right?
Yeah, I have to say, yeah. So this is also a type D connection. It's from the diagonal also to the marginal branch, as you can see here. But as in every anatomy, we don't have only one connection, but we concentrated on the biggest one. As you can see here, this is also type E connection. So from the apex, we have also here a connection, epicardial connection to the circ. You can see, and it's a second case. So I take an 8 French. In here is a boss cabbage. It's a woman, and it's an occluded circ. So I have seen first this apical connection, then I checked over the diagonal branch, and I've seen this connection. And this connection, it's a tiny connection, as you can see here in the right image, and I tried to record everything, but yeah, I couldn't record 100%, but here you can see how I passed it, and you have to search a little bit the right way. Then, as you have seen, there was a knuckle, finally the wire created a knuckle, and what you can do sometimes with this Xeon Black is that when you have a knuckle, you can slide gently, very gently, try to push it a little bit forward. I have another example, and this wire stays in the Westlache ejector. I mean, we can't recommend this for sure to everybody. We shouldn't say that's a general recommendation, but I can show you another case afterwards. So finally, you can see how the Turnpike LT went up retrogradely, and then the wire ended up in the bypass, in the wing graft. So what I did was a super selective injection over the microcatheter to find the right way. So I've seen, okay, there is, you can see here, so proximal from the vein graft, there you can see the right pathway. So I took an finally ultimate wire, and this ultimate wire ended up in the same guiding. And here you can see a tip-in technique, the retrograde wire. I put the retrograde wire in the antegrade fine cross. Can you see it here, Manus?
Yeah, absolutely. That's great.
So the question is, why am I doing this? As you've seen that this connection which I passed, it's very thin. So what I try to avoid is to do stenting and balloon dilatation and working with stents with this internal coronary loop, because I believe that when you got friction or tension on the loop, which can also we all remember our first retrograde cases where we have also strangulation sometimes of the heart because we didn't realize this sometimes, yeah. But when this happens in epicardials, it can rupture. This is the shear stress, what I'm talking about all the time, and then it can rupture. And to avoid this, I try to end up my case antegrade, and here I check with the microcatheter that I'm the true lumen antegradally, and this was after stenting the circ and left main in the right picture. So the next is a young guy, about 45 years old.
One question came is that, do you always do TP-in for the epicardials to avoid the stress as you mentioned, or you sometimes externalize anyway?
The tip-in. Okay, it depends for sure. When we have a very big collateral and I need a lot of, where I say I need maximum of support regarding my PCR, then I'm relaxed. But when I have a tiny epicardial, that's always a problem. Then I try to go for antegrade approach. So I do tip-in or try to end up with tip-in or rendezvous technique. So I try to do the stenting and balloon dilatation with an antegrade wire. Yeah.
And another question that came is, in those bypass patients where the perforation can cause this localized tamponade, what do you recommend? Are you a little more conservative in terms of previous bypass and epicardials, or you're okay with those?
So I at the end of the talk, I have a complication. I have a complication regarding this. If it's okay for you, we talk about this at the last example. Is it okay?
Perfect.
Okay. Yeah. So this is a 49-year-old man. He has a diffuse disease in the LAD, proximal part of LAD, and the circ is occluded, as you can see here. So this is probably the most easiest case, as you can see here. It's a very nice epicardial collateral, so which we could pass. I did superselective injection to understand the morphology of the collateral, and here is how the Xeon Black wire behaves here. Went to the wrong direction, then it took the right curve. Yeah, here you can see it, and then just bring it forward. And here's also the Turnpike LP. Which is really a very, very nice device, as you can see here. So, finally, yeah, we end up in the retrograde. We could get with directly wiring in the distal circ. We did a rendezvous technique again. So I put the microcatheter, the retrograde microcatheter, in the guiding and intubated with an antegrade wire the microcatheter, and so I did a normal antegrade PCR, as you can see here, and balloon dilatation and stenting with a stentis, a self-expanding stent, and that's the result. So, yeah.
One more question regarding the single. I see most of your cases with a single guide. Many people here in the U.S. like to do the ping pong, the two guides. Any thoughts? Do you think one guide is enough, or two is easier, the same, or what are your thoughts on that?
So I'm always thinking about the patient. So I mean, two punctures are not a problem. We know it. I mean, if we're experienced operators, but if you can avoid it and if you can do it with one puncture, I think it's no problem. I mean, you have to know the limitation, but
sure.
Also in the first live case, I had an 8 French launcher microcatheter, and you can bring in 8 French an IVUS and 2 microcatheters, 2 Corsairs. And I mean, the limitation when you go down to 6 French is then when you have a microcatheter in, it's very difficult to bring a stent in. So then you have to go for deep pin or rendezvous technique. In 7 French, you can do it. You can bring, but you're limited with a Corsair, and then a 3.5 stent won't pass. So these are limitations sometimes, and so. But I think it's no problem to do it with a single guide strategy. Yeah. Yeah. Okay, here is a type B collateral connection. I'm going now to the ipsilateral cases from the RCA, which we didn't have seen so much, so I never seen it before when I started to do this, Manusev, to be honest with you. And this is my first right-to-right case, which I show you today. And it was a case in a different hospital when I was as a proctor, yeah, the guy, I was standing behind him, and he was also a routine operator, but not so on CTO PCI, but he couldn't get a wire, bring a wire in. We tried, he tried, and then I said, I will overtake this case because I saw this very nice ipsilateral collateral, and I brought the wire, and it was normal Scion wire. I checked on the left system, and I said, oh, okay, it works. And then I brought my Corsair down, and I was at the distal cap, and yeah, so for an experienced operator, it's not so difficult if you have an antegrade wire to puncture with if you have a retrograde marker wire, in this case, to puncture with an antegrade confianza, which I did. So I had a retrograde marker wire, and I was finally lucky to puncture within confianza and solve the case. And here you can see the epicardial connection, and Corsair could get very nicely over it. So this was a little bit a different case. This was actually a live case in Stuttgart Heart Live, where I was invited to do this case. Very tortuous epicardial collateral connection. It's a type B connection to the PDA, so a PLD branch. So yeah, and here you can see a super selective injection with Corsair, and here you can see the Scion black wire again. And after the third loop, you have so much friction on the wire that you have to be very careful. You shouldn't go on because you don't feel what's going on there. So what I do is I try to bring my Corsair gently forward, and then you can go for the next loop. Have you seen it? Yeah? Yeah. Okay, the Corsair comes, as you can see, yeah. So you have to be a little bit careful with the device, but then the wire jumps a little bit forward here, as you can see here, yeah, and you do the next loop. So, and, okay, and this was after externalization and after stenting the vessel. It's a really very big artery. So yes, this was also a really similar case. It was also a physician, and it was an occlusion of the RCA. So what I tried is just I said, okay, it's a straightforward case. I can make it probably antegradally. I also did it antegradally. I did a balloon dilatation. What I've seen then was that the whole PLD system was not here anymore. So I couldn't get it. I tried to go in, but I couldn't get it with antegrade approach. So what I did is I've seen these epimyocardial collateral connections. So I took a fine cross and cyan black wire. I passed this connection. As you can see it here, I'm in the distal branch, and then I tried to bring the fine cross down. It was not possible. So what I did in the distal RCA, as you can see in the right image, I trapped the wire. So I trapped the wire there to bring the cochlear down, and finally I could do externalization and could stand the vessel, and I had a nice result. So it was also an interesting case, I have to say. So this is a ping pong case, and I can also tell you the reason. As you will see here, this is what I say a septal right destinance septal artery, septal connection to the distal RCA. So it was not very difficult to pass this, and then I could also bring cochlear down. I checked over the left if I'm in, and finally I had a little bit problem with the backup, as you can see here in the right image. So I put a wire down to the RCA to a side branch, and like an anchor balloon, but sometimes it's also enough. It's not necessary to deflate the anchor, to inflate the anchor balloon. You just let it like there. It will increase your backup support. And finally, I couldn't bring the cochlear completely up. So what I have to do is I snared this wire, and so I have now a ping pong, because I have not enough backup for making the procedure with one guide, and I had a 7 French guide, and the second was a 6 French, and then I could complete this case. So the next is also an RCA occlusion. This was a patient finally. When I saw him the first time, he had only one graft, and this graft was to the LED and had multiple stents in it, and the rest was completely occluded. So what we did is we opened the RCA, we opened the circ, we opened the LED, and then he came back again with an occlusion of the RCA. And what happened to me was, when I went retrograde, I could go to the PDA, but at the PDA side, when the wire came in to the PDA, I made a dissection. But I stented it, but I had a dissection there, and I only realized it after the procedure, and so he came back again. So this was the situation. And as you can see here, you have also some connection, some filling in the distal part of the RCA, where the crux cordis is. And I didn't want to go again over the septum, because I was afraid to go in again to this dissection which I created retrograde. So I brought the wire in and a cochlear, and the cochlear made it to the distal part of the RCA, as you can see here, with a super selective injection. So finally, I could bring a cochlear up first with a confianza wire, and then with a Gaia second, and then the Gaia wire jumped in the aortic root, and finally I was a little bit surprised because it ended up in the circ, so it was a Gaia wire. So I was lucky that it didn't perforation at the marginal branch here, but I snared the wire and in the truncus brachiocephalicus, and there I couldn't bring down the catheter, because there was such an but with a second wire, it was with a normal wire, it was possible to G guide. It was possible to bring the second guide down, and so we had also ping pong technique here, as you can see here, and in the right image, you can see at the distal part here a dissection, some dissection membrane. I brought the antegrade wire in, and I brought the crosshair in here over a mother and child catheter, and I was again in the subintimal space. So what I did here is I took a dual lumen microcatheter and a twin pass, and I had one wire in subintimal space and puncture with a filter XTA in true lumen. So as you can see here, this was the subintimal space, and the black wire is the wire in the true lumen. And this was then after stenting the whole thing. And yeah, a little bit complex procedure, 210 minutes of procedure time, but it was a really tough case. So another case is a case with a type E connection of an RCA. It was a patient with a with renal failure and really low ejection fraction. It was he had a really bad heart failure, and he was going to start with hemodialysis. So what we tried is to use less contrast as it's possible for us. So we did a normal dual injection, and here's a GR microcatheter. And what I've seen here is that this catheter, this 7 French guide, shows also a way to the right coronary artery. So I put a second guide in the true lumen from in the true ostium, and I did a dual injection to realize the anatomy of the right coronary artery. So I tried to go directly retrograde in this case. I put a modern child catheter. In this case, it was a cyan black and enhancer microcatheter, and I could pass this very, very tiny epicardial. When I go one back, I can show it to you again. It was this epicardial connection, as you can see here. Here, this one. Yeah. So again, we have to be very, very careful regarding rupture. So it's not the microcatheter and not the wire which destroy this epicardial, but it's the shear stress when you do stenting over an externalized wire. That's what I believe. So what I tried is, I tried to go also for dip-in or rendezvous or some connection to end up this procedure antegradely. In the left image, you see an antegrade corsair, an antegrade confianza, and in the right image, you can see a retrograde confianza, which was where I could puncture to the antegrade microcatheter, and here is the retrograde confianza, which did a tip into the antegrade microcatheter. So I just brought the antegrade microcatheter distal down, and then I had an antegrade wire in. I could save contrast with giving contrast over the retrograde microcatheter, and just put a stent on the distal part of the crux cordis. And this was the final result with 110 milliliter of contrast, and I was very happy that we could help the patient with this open right coronary artery. So one case was
question that came through regarding the contrast. So some people are saying that using retrograde you might save contrast, but sometimes crossing the collateral with contrast might take some. What is your experience on that? You think is less contrast with the retrograde versus the antegrade, or?
Yeah, I think so. I mean, normally we have to say that when we check our registry data, what we can see is that our retrograde cases have more contrast than our antegrade cases. But when you then check the GCTO score, you will understand why. Because the retrogrades are more complex cases. But in general, when you're going for when you have a clear retrograde pathway and you want to save contrast, it's also an option just to put a microcatheter down for a landing zone, and also to go for retrograde CTO PCI. I think it's a very we can save contrast with them. Yeah, when we go directly retrograde, I think it's because when it's a complex procedure, Manus, and you have one wire and a second wire, and you have always to visualize your landing zone with the left system, so it will take a lot of contrast regarding this. So. Here is a case, also a CTO PCI with a reocclusion finally, and which I did, and so it was a 7 French radial approach, and what you can see here is first the ostium had a problem, but there was a epicardial collateral connection to the distal part. So what I did here is I put a wire in, and as you can see here, again, a seam plaque, and this seam plaque created a knuckle. So, and just look what this knuckle did. But, I mean, this knuckle just went slightly forward. Yeah. here I brought the crosshair down, and then it ended up in the distal part of the RCA. I was really thinking about showing the slides or not, yeah, because that's not the normal manner how I pass epicardials. But when you have these CC1 connections and you are really careful with the Xeon black and you are only pushing them very, very gently, not too aggressive, sometimes it's go forward from loop to loop, loop to loop, loop to loop, and then it's an easy passing. If you're doing this with a normal Xeon, with a Xeon blue wire, rupture will be for sure, I think. But this is because it's plastic jacket, it stays in the structure. But I can't recommend to do this at this moment yet because we have too less data. I have to say this, Manos. Yeah. So, interesting thing is, can you see here? This is an anchored balloon. Also interesting experience. It was 3.5 balloon, and what I did is I increased backup force, and when you rotate the crosshair can pass through. So it's not that you fix the crosshair and the crosshair can't move anymore. So when you take not too much pressure, 8 atmosphere, you even can bring the crosshair through and fix it in the same vessel. That's an interesting manner to increase backup. Okay, on ipsilateral cases. So then I brought the crosshair down, and I get retrograde, as you can see here. But finally, I couldn't bring the crosshair and the wire up. I couldn't bring it up anymore. The crosshair and the wire. I have an image afterwards. So what happened is that I over-rotated the crosshair with the confianza, and I couldn't even bring the confianza wire out of the crosshair. So I had to pull out the whole system, and I was lucky that the collateral didn't rupture with the confianza at the tip. So I came back this time with a turnpike OP. I did the whole retrograde again. And I had to do, in the stand, I had to do a reverse card to get the retrograde wire up to the, in the antegrade guiding catheter. I could do an externalization. And here, I couldn't bring the balloon down anymore. So it was not possible to bring this balloon down. Sometimes, when you can't bring the balloon antegradally anymore, it helps to modify the block with pushing on the retrograde microcatheter. Yeah. So sometimes if antegrade balloon passage fails, you can help you just to modify the block with pushability on the retrograde microcatheter, as you can see here. And this is also very interesting because I blocked the balloon and tried to bring the microcatheter down. And here you can see normally what happened with the turnpike. It goes like a conus, and sometimes you have the problem of the involvement of the tip of the confianza. But this tip goes, it makes like a conus. And finally, after balloon dilatation, I realized that a 4-0 balloon I couldn't expand it. And this is a cutting, 4-0 cutting. A 4-0 cutting finally, and we shouldn't go up with this flex no more than 10 atmosphere, but I have to tell you the truth, it was 24 atmospheres in 3 minutes of time, which I waited, then it suddenly makes bloop, and it opened up. So time is also a manner on the angioplasty, and this is, I put another stand here, and this is the final result. The PDA is open, to be honest, the PLD not, but that's what I could achieve in this procedure. And now I'm coming to the complication which I told you regarding Bos cabbage. I was thinking about this case, should I do it or not? Because as you can see here, it's a huge amount of calcium. Yeah? And yeah, so yeah, I need. I was thinking direct regarding. So that's unimpossible for me to do antegrade. I don't know if you're happy with this case, also with the secondary entry. But what I did is I checked the retrograde pathway. And this is sometimes, what should I tell you? when you have a very, very calcified, what I learned from this case, very calcified, very complex procedure, don't use these tiny epicardials. I will show you why. So I passed, that's not the problem. I had a retrograde wire in, but then you had antegrade and retrograde. You have a lot of calcium. And what happened here is that the corsair tip was fixed with the wire. So and there you can see what happened. So I couldn't rotate the corsair anymore. It was fixed with the wire, and but I rotated, but the corsair didn't move. And suddenly I had a penetration to the pericardial space. Watch. It was such a loop to the pericardium space. I've never seen this before. Have you seen it?
You know, it's complicated where you put the knuckle and somehow it just happens, but mainly septals, not in. I haven't seen it in the epicardials.
Okay. So I was not happy, as you can imagine. And here, you know, because at this point, the problem was that I couldn't use this wire anymore, and also the corsair, because always when I tried to rotate it, I always got this prolapse. But I had a graft to the PDA. So I did a third puncture, and I checked the graft to the PDA. And what I've seen there was also, at the distal part, there was also epicardial connection to the distal part of the PLD branch. So I used this pathway, as you can see here, also again a cyan black wire, a very tortuous epicardial. And finally, I got the way through it in. The patient got angina, and I had to put a stent here in the PDA because it was diffuse disease. And then I brought an antegrade guideliner down and did a reverse card maneuver, as you can see here. And finally, I could open up the nice vessel. So, but now there was the situation where I had to bring out the corsair, and I was aware of it, and I let the wire in, and as you can see here is that it's bleeding, and it's creating hematoma. So the only thing that I could do there was to put coils in. I coiled this pathway. There were 3 sites where I had to go for coils. Yeah? I had to coil this pathway and also this connection, this epicardial connection also. So, and here you can see the confianza, the 12 Bram tip, which was fixed on the wire here. It was amazing. And here you can see a hematoma, which we've seen no effusion, but an hematoma. Yeah? And but patient had no problems. So she had a prolonged stay in our hospital for sure, also in ICU, but she had no problem in the next months. And regarding the whole complication regarding these ipsilateral or contralateral cases, when we go over epicardial collaterals, is that what I can tell you is that on these 44 ipsilateral cases which I analyzed, so we had collateral injuries, yes, for sure. In about 7%, we have a collateral injury of epicardial collateral connection. Major, which means that I had to treat them, it's 2.2%, it's not 0. We have to deal with that. Minor means that we didn't have to treat this connection, we didn't have a tamponade. But this, when you have a major epicardial collateral injury, it causes for sure a pericardial tamponade. That's what we know, but we didn't find in general more complication regarding ipsilateral approach to the conventional contralateral approach. What we have more in contralateral approach is dissection of donor artery. That's what we're seeing more often. So my conclusions, epicardial collaterals reveal a useful and passable pathway, increasing the rate of retrograde success. Epicardial collaterals were used in about 70% of ipsilateral CTO PCIs. It's a bailout strategy. We should have bailout strategies, and we have to prepare them before the PCI. So we should be used on coiling, embolization with microspheres or fat or whatever. And I think it's not represents the first choice of retrograde approach for sure. Yeah. So thank you very much.
Perfect. That's awesome. That was an awesome presentation, Kambis. Really enjoyable. There's one more question that came through regarding the timing. As you say, it's not your first choice. So would you typically put first, if you have a septal, I would call it septal first and leave it as a second choice for the epicardial? Is that right?
Pardon me, can you give me the question again?
The question was from one of the attendees that
yes.
if you have the option for both epicardial and septal, that you obviously try for the septal first. Is that right?
Yes. Yes. I do it.
Epicardial.
Yes, for sure. Yeah.
And then another comment that came through is that how about giving thrombin through the microcatheter in case you have this perforation like the last case you saw? If you could use some thrombin, do you think that would do the same job as the coil implantation?
I think so. But finally, we have the problem that we don't have the thrombin anymore. We couldn't get it in our hospital anymore from the States. I don't know why. And so I have to deal with some Boston coils, but it would be more elegant, for sure. You don't have this piercing, which I don't like.
The important thing is that I think I like the way you handle it, that you didn't remove everything out. You just let it there in the meantime, because you have to get the lesion treated anyway, and then you fix it at the end. So that's nice. You didn't have the continued bleeding during the case having all this. That's a great tip. That if you have this perf, leave the catheter there until you're able to treat it. Is that how you approach those?
That's a very, very good thing what you tell here, and I have to be honest. I had to do yesterday. Yes, I had yesterday the situation. I passed also a very nice epicardial. There was no problem at all, and after stenting, during the stenting, I did an IVUS, and finally my distal wire tip knuckled. It was a normal sound wire, and destroyed the epicardial. So. And what I did is I passed it again, and then I put a turnpike in, and this it makes also a tamponade. It makes also so that when you have a microcatheter in, it's like, have you got experience when you make a radial, when you destroy a radial and you pass the radial with the catheter and you end up the procedure, and afterwards you check the radial is okay, you have no perforation anymore. And this also works on epicardial sometimes. Then when you have an injury and you just let the microcatheter in, sometimes the bleeding can stop. But finally, the advice is to let the microcatheter in to end up the procedure and then concentrate on the perforation. Yeah. If you have the wire in. Yeah.
Sounds perfect. Excellent. And then another question that came through is regarding injecting through the microcatheter in epicardials. You do this as well, right? It's apart from the central injections, just to see where you're going, you inject through the epicardial as well?
Yeah, I do this, but we have also to be careful. As you can remember, in New York, one of the greatest operators of the world, even Bill, he had this complication. So when we are too deep with the microcatheter, and then we flush, and with a tiny CC1 or 0 epicardial, even the flush can destroy. Can destroy the epicardial. So we have to do it very gently. Just be a little bit more distally, just take a little bit of some millimeters, be away, and just do a gentle injection. But for me, the deep injection is very useful because I understand the morphology and for passage, it's important.
Perfect. Well, I think it's been past the hour, so I would really like to thank you again for this expert opinion. Just a warning for the viewer that these procedures are the advanced techniques, so it's for very, very experienced retrograde operators. It's not a beginning procedure. And once again, I would like to thank Dr. Mashayekhi for the wonderful presentation. Thank our sponsors, Abbott Vascular and Terumo, and thank you all for being with us. So thanks again, Kambis, so much, and we really appreciate your time.
Thank you very much for the invitation, Manus. Thanks a lot. Yeah.